Thank you so much for taking the time to be here today. I really appreciate it. Could you take a second and introduce yourself and tell us a little bit about, who you are and what you do? And then we're going to talk about some of the differences between the way that boys and girls present in the autism world.
Yeah, absolutely. Thanks so much for having me. So, Dr. Taylor Day, but I go by Dr. Tay on pretty much all things like social media. And I am a licensed psychologist. Specifically, I work with kids ages 1 through 12. And I own my own practice called Dr. Tay Concierge Clinical Care. And what I do as part of that is I really focus on the diagnostic process. So I'm usually one of the people that are telling families for the first time that their child is autistic. Although I also get a lot, which feeds into today's episode, a lot of like second opinion consults where it's like, families were told no, but then they still think it's autism. And so then I'm redoing the evaluation process. And I also have therapy services as well, where I really support, you know, largely it's working with parents of autistic children. I'm a big proponent of quality over quantity of services. And one of the ways that we can really do that is by empowering parents to support their kids in a affirming way. And so, yeah, so ultimately do all of that as part of my practice. And additionally, then, provide free education via my podcast, which is Evolved with Dr. Tay, and social media as well.
Very, very cool. And we're going to do a follow-up episode at some point in the near future talking about the online diagnostic process and stuff like that, because I think that's a huge tool that people need to be aware of is out there so that we can avoid some of these, wait lists. But today, like I said, we're gonna talk about some of the maybe the challenges in diagnosing girls with autism because they do present very differently, and so a lot of times they go undiagnosed or they're diagnosed later in life.
Yeah.
And I think you were kind of alluding to maybe uh, you get second opinions as to whether they are or they aren't. Probably. I mean, I
Yeah.
guess that would be the only are or aren't. Yeah, either way.
Yeah.
Uh,
No, but
but you
sometimes
know what I mean?
what's co-occurring as well. That comes in. If we're going to talk about this, anxiety is something that frequently co-occurs with autistic girls. And so they can be diagnosed as having anxiety, but then the autism is missed.
Okay. So let me just let's start like this. So like um we know that boys are more commonly diagnosed than girls, right? They're outpacing the girls there. Um and my understanding is that we believe that's largely because girls present so differently that they're much harder to diagnose because um some of the behaviors can kind of be hidden in things and things like that. So can we talk about uh some of the challenges that you find when you're evaluating, a young girl for something like autism?
Yeah, I mean, I think first, just to comment on this is, yeah, we do see a lot more boys diagnosed than girls, but we're stuck in this vicious cycle where the diagnostic criteria, all of the diagnostic tools were developed basically on this male profile, and largely too, just to point this out, on white males. And so there is a lot of like factors that come into play. And so sometimes I think one of the things that can happen too is, I find that clinicians sometimes can over rely on the tools. And we have to remember that any of these tools or assessments, whether that's a questionnaire you're filling out as a parent or something even like the ADOS, the Autism Diagnostic Observation Schedule, none of these tools are perfect at diagnosing autism. But then if we have this layer where it was developed based on kind of the male presentation, sometimes then they're not capturing this female phenotype or this female presentation. And so a lot of times too, like in my practice, I was saying like these will be, I find it largely with girls. It does happen with boys as well, where it's like a clinician says, oh, well, they're not autistic because they're making eye contact, or they're not autistic because they can have a conversation. Or, yeah, we just didn't have enough, because they presented so differently. at in this clinical setting or at school than they do at home. And so then the clinician ends up saying, I can't diagnose autism. And then parents, are seeing their kids day in and day out and going, but everything I read feels like it fits my daughter. Like, and so then they'll come to me and say, we tried this once. Here's where it went kind of awry. What do you think? And I will say more often than not, um, I'm ultimately diagnosing those girls as autistic because I find we have to really factor in all of these pieces as well as the concept of masking comes into play too.
Well, and that's what I was gonna get to that one too. So let's start with this. So how do girls tend to present differently than boys?
Yeah. I think we have to take a step back and think about neurotypical differences first in order to understand how then autistic girls present differently. We know that, on average, of course, there's exceptions to this, but girls are very social beings, and they really crave connection. And so we often see, stronger kind of social, emotional development in girls compared to boys for neurotypical kids. And so then what happens with autistic girls is a lot of times then we're comparing them to ultimately like neurotypical boys, and then we're saying like, okay, here's this diagnostic criteria of what it looks like in autistic boys. But wait, these girls, they feel more social, they want connection, they are having conversations, they ultimately they have friends, all of these areas can really throw things off. And so what we need to do is take this step back and compare girls that are being evaluated for autism compared to neurotypical girls. And I think that's where we start to see some of the deviation become more clear, or the differences become more clear.
So okay, so my one of the things that I understand about, and I have all three boys, like we've talked before.
Yeah.
Um, One of the things that I am aware of is that girls tend to be better at masking. Is my understanding that's one of them. And like you talked about, they tend to be more uh, social by nature, and so whether a girl is autistic or neurotypical, they're probably prone to the same tendencies, right? And so like what you're saying is when you compare, uh, who might ultimately be an autistic young girl to an autistic young boy, you may have two very different things that you're dealing with because one is very social and the other may not be, or symptoms may not come across the same way. You got to dig a little bit deeper, or maybe they're
Right.
misinterpreted, I think.
Yep.
So what are some of the common, like in your practice, what are some of the common things that are indicative of autism in girls that tend to be missed?
Yeah. I mean, I think talking about friendship, for example, if we ask this question of, does your daughter have friends? It's like, yes. Okay. That's great, And so sometimes as clinicians, we'll stop there. We're like, oh, but they have friends. So then they don't have differences in developing, maintaining, and understanding relationships, which is one of the key criteria that a individual has to have in order to be diagnosed as autistic. But this is where I like to often think about the quantity of something versus the quality. And so I call them quantity and quality traits. Quantity traits are saying more of that yes, no. Do they have friends? Yes, no. And that's a lot of times more of that stereotypical presentation. We hear yes, and then we just naturally can make assumptions of what the nature of those relationships look like, versus when we start to dig into more of the quality, the presentation of it, the nuances. Couple things like with friends, for example, have they had these friends since they were really little, right? Like, is it that, this was a group of girls and, they've connected? Well, what about developing new friendships, right? How does that go? Or another example that I hear a lot is, yeah, my daughter has friends. And I'm like, okay, tell me a little bit more about that. Who are the friends? How long have they been friends? Is there any conflict? And then you start to see this pattern of they're actually really great at developing the friendships, but then maintaining the friendships becomes more difficult. Where it's like, oh, but here's the thing, like, if they don't follow her lead, then she'll just walk away. And it's like, okay, it's great that she knows how to take charge and lead and loves that. But we also, for these reciprocal relationships, we need flexibility. And so that's where we start to really dig into what does the quality of these relationships look like. And I feel like we could do this in many ways on, like, in terms of the social realm of every single kind of criteria we're looking at. Eye contact, another thing. Yeah, my daughter makes eye contact. Okay, what does that eye contact look like? Is that eye contact only existing when she's talking about her preferred interests, versus if you introduce a topic, is she like looking off to the side and wandering away? So I think that becomes important. Conversation becomes important. So there's all these like quality factors of like, let's dig deeper beyond this surface level. Yes, no. Do they have friends? Do they make eye contact? Do they have conversations? All of this. And I think also, just as a whole caveat, what's important to remember is no one symptom is going to say yes or no if a child's autistic. It's a collection and pattern of symptoms that we're ultimately looking at.
So, what is the average age of girls that are maybe even just going through your practice who are looking to be evaluated? Is it something that parents are noticing, or is it um, that teachers noticing? Because like with boys, like with my boys, I mean, I didn't know what autism was for my oldest, and then I thought what autism was for him was it, right? And then the other
Right.
two presented very differently, so I was kind of lost. I didn't see it, but with girls presenting very differently than boys do, like how much later in life are they getting diagnosed, and then how much of a detriment is that to
Yeah.
them? Because we know that early intervention is important. So what are you kind of seeing there?
Yeah, and I will say that there's huge, huge studies that are done by the CDC on like prevalence. And I actually haven't looked at recently what the average age of girls being diagnosed is. But what I will say is, I will say it's usually the girls that are presenting to me, they're usually about 7, 8, 9, somewhere around that. It's not saying that I don't get, young girls. Like I recently evaluated a 3 year old. And that's pretty common in my practice. But I think that two areas that I find usually lead to this autism diagnosis is one, when they typically start school. And I know for at least one of your younger ones, that was like, I think he
Yep.
started preschool, and that's where you started noticing some of the differences of, okay, they're around their peers, you're noticing what their peers are doing. And maybe if you have a really highly in tune teacher, the teacher is picking up on this and saying, like, here's some of the differences that I'm seeing. I think that happens quite a lot. I also think when language delays come into account, or the other side of this is highly advanced language, where it's like by 3 years old, this little girl is reading what's called hyperlexia. That's not uncommon too. Sometimes that can help, make things stand out as well. This language piece coming into play. The other place that I really see it though is, more this elementary age. And there's a reason for this. One is usually about second to third grade. What we see in terms of like relationships is kids go from being friends with everyone in their class to starting to kind of like segregate out and having closer friends and having a pod. And so sometimes it's like, well, my kid doesn't have that. They're kind of on the periphery, and they start to notice that. I also think that's also when teachers start to notice it. Or I also am hearing a really strong uptick in anxiety at this age, where it's like, yeah, my daughters are always been a little anxious, but like now she's anxious all the time, to the point that it's hard for her to access things like school or social situations.
Is it true too that some of the more stereotypical like girl behavior at that in that age group can kind of muck up the water a little bit in a way, like because we tend to think of girls as being more emotional,
Hmm.
right? Maybe starting puberty at that earlier age and all of that kind of stuff. And so when you're dealing with things like emotional outbursts or meltdowns or things like that, does that sort of just kind of blend in with what would be otherwise kind of typical for that age group?
Yeah. I mean, I definitely think that can come into play of like, well, is this, she's just really in tune with her emotions. I think another one again is like advanced language of like, oh, girls just tend to speak earlier. All these generalities. I do think it doesn't muck up the diagnostic process, but I think it can muck up them actually getting referred for an evaluation.
I guess that's what I mean, like the warning
Yeah,
signs that people should look for.
totally.
Because like with when we talk about like warning signs, I mean, there's all those things like missed milestones and not walking or not speaking or not having so many words, all that kind of stuff. But that can be very different for girls. And so if there's parents out there who have, a little girl and they're worried about something, like what are the things that a parent of a young girl should be on the lookout for is kind of a warning sign or something to maybe get checked out? And then is there a better way to go about doing it if we're kind of stuck in this arena where the diagnostic process in most cases is not designed to really evaluate them as, for who they are?
Yeah. Yeah, so I think some common presentations I see again this anxiety piece where especially anxiety that doesn't seem to be improving, where it just feels like your kid's always anxious. I think that can be a really big tell that I see in females. And I do want to caveat, obviously there's so much variability within females themselves, but then I'll see these same traits in boys too, like more high masking boys, which I know we said we were going to get to, and we'll circle back around to the masking piece. But I think, difficulty with relationships where it's like more the same thing keeps happening, or it feels like they have friends, but maybe they're on the periphery. I also think a lot of times it's interesting. So, like intense interest or like special interest, they tend to be more developmentally appropriate in terms of theme. So like I had a little girl, I believe she was 7, obsessed with squishmallows, right? Well, that's developmentally appropriate. Kids love, girls in particular love squishmallows. But then when I started to ask the parents more questions about this, of like, okay, tell me more about it, it's like, it was almost like she had to collect all of them. They all had their certain space. Like she had a routine that she had to do with them before she got out the door, and so, or sometimes it also can look like a special interest can actually look like a peer too, where it's like, let me tell you everything about this peer. Or like I had another little girl who would talk about gymnastics and wearing her leotard all the time, but it's understanding of like how frequently is this happening. I also think emotion dysregulation, especially which goes to the masking piece, this rebound effect, where, I hear this, I literally could quote it all the time of like, oh, she's my favorite kid in class. Like she's so compliant. I wish I could like duplicate her and have a
Mhm.
class of all these little girls. I literally just did an intake the other day that the teacher told the mom that. But then what's happening is then when this girl comes home, and this is a common pattern, it's like complete meltdown because she's holding it together all day in school. And then there's this rebound effect. Her bucket becomes filled, she's in her safe space, and we're seeing a lot of that dysregulation as well. And then the other piece that I'd look for is like a lack of flexibility, like always needing to be the leader, always needing to be in control. I think those are really important things to look for too.
Yeah, so like if they're playing a game, it's playing it their way. If it's deciding what game to play, it's playing the game that they want to play. I yeah, I know people like that, and it's really interesting as we're having this conversation. It makes a lot of sense. Um, so let's talk about the masking
Yeah.
side of things, because I think a lot of like what you were referring to, um, like I always referred to it as like my kids would compensate really well when they're at school, and when they would get home, they would fall apart. But as I'm better understanding things as I get older and kind of move farther along in this journey, like they're exhausted from the masking that they did at school all day, right? And then they come home and it's a place where they don't have to do that anymore, and they can just purge. And that can be very frustrating as a parent because the school doesn't see what you're seeing at home. And so there's that can be kind of a, you know, issue when you're trying to work out things like IEPs and additional help and whatever. But
For sure.
so for people who don't know what masking is, can you just kind of explain what masking is? And then if it is different for girls and boys, can you explain how it might be different?
Yeah. I mean, what masking ultimately is, and I'm going to acknowledge this. This is my understanding by listening to autistic individuals. I don't, necessarily know from a firsthand experience, but it's kind of like almost this like adherence to neurotypical standards, like recognizing that there is this social rule, so to speak, and trying to camouflage or fit in or kind of downplay some of those autistic traits. And so sometimes, just to clarify, it can be a very intentional process of like, ooh, I want to fit in. I feel the pressure to fit in. Other times it can be for safety reasons too, right? Like, and both sometimes physical safety as well as psychological and emotional safety of like, I don't feel safe to be myself in this environment. And therefore, I'm going to kind of suppress some of these traits and try to look more like my neurotypical peers. And so I think that the challenge with this is, ultimately it can be very, very exhausting. And you're having to work so much harder to kind of hit these neurotypical norms to blend in, and that's where we can see this rebound effect. So I don't think that there's differences between males and females in terms of masking, like of what it looks like. I think it does happen more frequently with girls. And I think this comes back to, again, that kind of social attunement that girls just like sometimes naturally have a little bit more of or can be more advanced relative to their male counterparts, of like understanding. And a lot of these things are unspoken. So it's like understanding these unspoken rules and being like, ooh, I should be doing that because it's like maybe another kid in their class is getting acknowledgement for that, right? And so it's like, I want to be, the teacher's pet. I want to be liked by the teacher. I'm going to do that too. And not realizing, that it's okay to be different. It's okay not to do it that exact way. And so there's this attunement to the environment. I think that happens more frequently with girls. And so then they try to downplay, their symptoms or their traits.
Um, so when it comes to, the parents out there who are listening, who maybe, have autistic boys and maybe they're concerned about their daughter, but that's very different. Like what are like the top three things that would be things that would be flagged for you? Do you know what I mean?
Yeah.
That if they see it, that they should get help, and then follow up with that with just what, like what direction should they go in? Should they just go to the pediatrician, or is
Yeah.
it better off going with someone who specializes in like diagnosing autism in girls? I guess if that makes sense.
Yeah, absolutely. I mean, I think first and foremost, if you already have one autistic child, the likelihood that you're going to have additional autistic children is about a 1 in 5 chance. And so, that right there, if you already have, like, say, an autistic son and you're wondering about your daughter, there's a significantly increased likelihood. So, I immediately am going to get way more curious about that. And I think some of what to keep in mind is not only do you have a 1 in 5 chance of having an autistic daughter, you have about a 3 in 5 chance of having a neurodivergent daughter. And they really haven't done kind of sex differences of male versus female of those prevalence, but generally speaking, when we study younger kids, this is what we see. And so that's going to be something that is going to pique kind of me in this, is like getting more curious, especially too. I think the second piece I come back to, I talked about some of the ways that this presents already, but listening to your gut. Like, do you feel like your daughter is different? Do you feel like maybe she has different support needs and maybe it doesn't present exactly like your other autistic child does? I mean, even between girls, every kid, autistic kid can look so different. So don't write it off because of, well, they don't. look like my other child, or they don't look like what I know about autism. I find most times parents have this like gut intuition that there's something going on. So seeking that out. And the third piece that I really want to emphasize is a lot of times autistic individuals, autistic females in particular, but those who mask will talk about like how effortful it is, how hard it is, how much they have to work. And so I would, if your daughter has communication in a spoken way where you can get in these conversations, start to get curious of like, well, what's it like for you when you're in these settings, And if your daughter is describing that it feels really hard or really exhausting, and even if the language isn't there, if again you're seeing that rebound effect, you're seeing her go on a play date, she has so much fun, she hits the wall and you guys have to leave, or you get in the car and she's losing it, those are indicators, behavioral indicators she's having to work harder. And so those are things that, less tangible but are super important of, do I proceed with this evaluation? I do always, as a starting point, recommend talking to your pediatrician for referrals, but also understanding that even if your pediatrician says they're not concerned, that doesn't mean you don't have to be concerned. And you can still ask for that referral, or in particular, sometimes you don't even need a referral if you're going in within your insurance network. It depends on what your insurance looks like. But if you're going outside of insurance, you definitely don't either. So just realizing you do potentially have options, even if your pediatrician doesn't refer you. But I would be looking for a provider, whether that's a psychologist like myself or a developmental pediatrician, or sometimes neurologists will diagnose. There's lots of different types of providers that can diagnose, but someone who has a lot of experience with high masking girls. And so I always encourage people, interview the provider that you're thinking of going with, asking like, how often do you see girls, how often are you doing second opinion consults, in diagnosing, how often are you seeing masking, how do you navigate masking, if my daughter is going to mask in this evaluation, how are you going to factor that in, and also like what components are going to inform your clinical decision making. If they're putting a lot of stock in, well, yeah, we'll observe her and see what she looks like, and we're going to do all this testing. Well, what happens if your perspective is different than what you're sharing with that provider? It really should be this comprehensive picture. And I think sometimes this is where I find clinicians get stuck, is they're like, well, she didn't meet on the ADOS, so she's not autistic. And it's like, yeah, it doesn't work like that.
Well, yeah, because like it'll be like where you've got 2 out of the 6, boxes checked or something like that, and because my youngest has ADHD. Well, all my kids have ADHD, but my youngest, he presented where he would just be. It was a nightmare at home, but at school, he didn't need any help. He was doing amazing, and it turned out to be that learning, like school, was his thing that he would hyper focus on.
Mm.
And so, in that type of environment, he was in his comfort zone, and anything outside of that structure, he would fall apart. Right. So, like, we would send the report things in for the teachers to fill out, and they're like, "Oh my gosh," like you said, "I'd like to clone him. Wish I had 30 of him in my classroom." And then you take that back to the doctor, and they're like, "Well, I mean, the teachers are saying like we're not having any problems, so I'm not sure what to do." And there's just weird things that can come up, and so the masking is one of them. And sometimes kids are just unique, and you have to look a little bit deeper. So maybe, if you run into a situation where you're uncomfortable with the outcome of an evaluation or something, you can get a second opinion. Like, trust your gut as a parent. I mean, you're going to make mistakes, but you know your kid better than anybody else. And if your gut tells you that something's not right, um, you're far better off following that and proving that it's wrong than to not do something and find out that it was right. You know what I mean? If that makes sense.
Totally. Yeah. I'm in the process of writing a report right now for an evaluation. And I am reading this report from another psychologist, and everything was described in context. This girl ended up getting diagnosed with learning disabilities, dyslexia in particular. And yes, this is part of her neurotype, part of how her brain is wired, but everything was explained away by this. And I literally was like growing increasingly frustrated reading this report. Well, to be candid with you, I'm diagnosing autism. The parents already know this. And I actually was talking to the mom about this. I was like, I'm frustrated of how everything is explained away. And it's like, that's where if like we're constantly explaining everything away, like this is a great time to be like, but is there more to this picture? And so realizing too that sometimes having additional diagnoses can delay that autism diagnosis. So ADHD is a great example of this. There's a lot of research showing that getting an ADHD diagnosis can actually delay the diagnosis of autism because then people attribute it to be all, these like ADHD symptoms, but it's like if you're like questioning like it feels like there's more, like that's a time to dive back in for sure.
Yeah, like I told you, I think when we were talking on your podcast recently, um, I was diagnosed with ADHD at 44 years old, right? And I was treated for depression and anxiety most of my life because that's how it was presenting, and it never really worked. And it wasn't until like I managed the ADHD that the other stuff kind of, I mean, it didn't go away all the way, but like it was, you can manage it better
Yep.
because you're addressing the underlying cause. And anxiety and ADHD and autism, they have so many overlapping symptoms, it can be very difficult to parse those. And then there's a lot of doctors I found who are very, they're maybe uncomfortable like when there's so much overlap. Like our docs used to call it like the water was so muddy, we have to, let's pick a direction, let's go in it, let's let the water settle and see where we are in 6 weeks or 6 months or whatever, and then reevaluate, and try and pick things apart. But it can be very frustrating when you're seeing something different than what you know the care providers are. Um and I think that's great advice when there is a comorbid diagnosis along with it, that it can complicate the process and make it, a more lengthy or more difficult thing. But you want to have an accurate diagnosis in the end,
Yep.
so you got to just kind of push through that, I guess.
Right. Exactly. And I think, again, coming back to trusting your gut in this as a parent. And as a provider, I say this regardless of you come to me or not, like you get to work with me or whatnot. But I want you to feel like you're seen and heard. That is like the biggest thing of everything. And if you're not, pivot away from that provider. So I'm not saying this so you're like, oh, come to me. Like, no, there's so many amazing, amazing providers out there who truly want to empower you as a parent and, really are going to work alongside you instead of like, oh, well, I'm in charge. This is my decision. I rely on parents as part of this because no, I'm never going to be the expert of a kid. Only the parents can be. They're so, again, I just did another evaluation, interestingly, a little girl, and this mom, and I understand this, like wanted to be able to tell me every story. And I'm like, I know it's really hard. She's like, I want to make sure it's not missed. And I'm like, I understand that. But some of it is, of course, we can't tell every story. This girl was 5, like we would be there for forever, but this is where it's like give me examples of this so then I can kind of put, I like to think of it like a puzzle, of like putting pieces of a puzzle together to create the full picture, and not in the classic autism puzzle piece sense, but more it's like it is like you're trying to figure it out. You as the parent don't need to figure out what this is where collaborating with the provider is important, but it's like I won't know I'm missing a piece of this puzzle unless you tell me that. And so feeling empowered is super super important, and if you don't, that it's okay to pivot and move to another provider.
I like that. I learned that with my kids, and it can be hard for parents, I think, to do that, to make that shift away or to ask for second opinion because they feel guilty or they feel bad or whatever. But you have to,
Yep. Yep.
you know. Um, what is the best way for people to find you?
Yeah. I mean, I post on Instagram all the time. So it's the Dr. Tay, DR, but there's periods in between. So the period, DR period, Tay. My podcast, Evolve with Dr. Tay and Rob. We'll be on it soon if the episode hasn't already aired. We just recorded that. And then if you're interested in clinical services, my website, drtaylorday.com. I can practice currently in about 40 states. I do all telehealth, which I know we're going to talk about, in a follow up episode as well. But that's where you can learn more about the diagnostic evaluation services. As well as therapeutic support services. And then I do, if you're outside of that, I do have a membership. It is not launched at the time of recording, but by the time this airs it will be up and running. That if you need support and really want to learn about neurodiversity affirming practices for your autistic child and family.
Very cool. I really appreciate it. I'll have all of that information in the show notes and the blog post and all of that stuff. Thank you very, very much. I really appreciate it. And I look forward to doing this follow-up episode too, because I really want to better understand the whole telehealth side of it. Cause like we do a lot of that in my house now, but not to this extent. And I think it's a huge tool that people need to be aware of. So they know they have options instead of just wait lists. So thank you very, very much.
Thank you so much for having me.